Bismillah ar-Rahman ar-Rahim. I am Dr. Nizamuddin Uthmani and I welcome to all of you to my YouTube channel. Today I am going to discuss one of the most important antibiotic, and that is the penicillin. Penicillin is basically a beta-lactam antibiotic. For today's lectures, we have certain learning objectives that describe the penicillin, their different types, their clinical uses, their adverse effect, and of course we will also discuss the resistance, how the resistance developed to the penicillin. What is the history of penicillin? Penicillin was the first antibiotic in the world, and it was discovered by the Alexander Fleming in 1929. And for that, he got the Nobel Prize. In the First World War, most of the soldiers and most of the people, they died because of the wound infection. But penicillin has saved so many lives in the Second World War, and it has produced magic response. Major portion of the penicillin was produced in 1939. Resistance, we will discuss that in detail. So for learning purpose, I can say that in the structure, why these penicillin are called as the semi-synthetic, because in the structure of the penicillin there is R group, and they attach different elements or different ions or different amino acid with this R group, and thus they change the nature of the penicillin. So actually the structure remains the same, like that of the natural penicillin, but by substituting different ions at the level of the R, we get different number of penicillin, and that's why these penicillin are also called as the semi-synthetic, because they are not synthetics, they are semi-synthetic. They just bring a little bit changes in the structure, and they are considered as the semi-synthetic. What is the mechanism of action? In the bacterial cell wall, there is a peptidoglycan layers. In these peptidoglycan layers, they are connected by a cross-bridging mechanism, and that cross-bridging mechanism gives strength to the cell wall of the microorganism. This penicillin, they bind with that particular proteins, what we call as the penicillin binding protein, and thus they stop the cross bridging of those peptidoglycan. And by blocking those cross bridging of the peptidoglycan, it makes the cell wall very much fragile, and thus there is rupture of the cells, and there is leakage of the intracellular material, there is movement of fluid inside the cell, and there is destruction, you can say there is a lysis or bactericidal activity of the penicillin. So penicillin just stop this cross bridging by binding with the enzyme, what we call it the transpeptidase, and thus it's disrupt the normal cell wall of the bacteria. Now, discussing these penicillin in detail, we already discussed everything about the penicillin. And you forget everything about the penicillin. It is just given orally. It has got the same mechanism of action. It has got the same indication, and it has got the same adverse effect. Now, coming to the Penicillin G, which is the benzylpenicillin. The benzylpenicillin, it has got different pharmacokinetic because it is acid labile, and we gave it parentally. Now, by giving benzylpenicillin parentally, it has got a very short plasma half-life. So if we combine the benzathine with the benzylpenicillin, its plasma half-life can be increased, can be lengthened, and we can even give in some disease once a month, once a week, like this, or once a day. So by adding benzathine, the natural penicillin become benzathine benzyl penicillin, and by adding procaine, the natural penicillin can become the procaine benzyl penicillin, or in shortly we can say the benzathine penicillin and the procaine penicillin. So then that natural penicillin G, which what we call as the benzyl penicillin, if we add benzathine and procaine, it's just pharmacokinetics property get changed the kidney, and probenecid, it's decreased the excretion of the penicillin. If you give probenecid along with the penicillin, its excretion is significantly decreased. So we already discussed this. By adding benzathine and procaine, we can just prolong the plasma half-life of the natural benzyl penicillin. Now, spectrum of activity. Remember, penicillin are basically drugs which are given to those bacteria which have peptidoglycan in their cell wall. We use penicillin only and only against the gram-positive bacteria because of peptidoglycan layer in their cell wall. We don't use penicillin in the gram-negative bacteria because they have got extra lipopolysaccharide layer out on the outer membrane, and we can't use the penicillin for the treatment of gram-negative bacteria. So we can use it in the streptococci, in the pneumococci, we can use it even in the anthrax, the diphtheria, we can use it in the clostridia and listeria. Apart from that, we can use it against the spirochetes like the treponema and leptospira. Treponema, which causes the syphilis, and the leptospira, which causes the leptospirosis. So we also use it against the spirochetes as well, and they are least effective against the gram-negative cocci and bacilli because of the extra lipopolysaccharide layers. So what will be the uses of these drugs? We use these drugs in the upper respiratory tract infection like pharyngitis, otitis media, tonsillitis, scarlet fever. We also use it in the rheumatic fever. We also use it in the subacute bacterial endocarditis. We can use it in pneumonia, meningitis, in ophthalmia neonatorum. These are the different uses. Apart from that, we can use this drug for the syphilis. If you are using benzyl penicillin, you give it daily. If you are using benzathine penicillin, which is a long acting, then you can give it weekly. For the leptospira, again, leptospira is an emergency and we need to use these drugs on the daily basis. So we usually use the benzyl penicillin rather than benzathine penicillin. For the tetanus, again, we use the benzyl penicillin rather than benzathine penicillin. For anthrax, you can use even the benzyl, you can use the benzathine. And for the red bite fever and actinomycosis, again, we can use the benzyl penicillin. For the prophylaxis, like prophylaxis means if you are giving this drug just to prevent the occurrence of disease, like for the rheumatic fever, we give benzathine penicillin, and we give that once a month, benzathine penicillin for the rheumatic fever. For the bacterial endocarditis, again, you can give that long acting. For the agranulocytosis, again, you can go for that long acting penicillin. So these are the different doses. I will not go for the doses in detail because you can go and you can study these doses from the book, but usually in case of prophylaxis, we usually use 1 million to 2 million international units on the weekly basis or on the monthly basis. While in case of short acting drugs, we use again 10 to 20 million units, but on the daily basis, and we usually add gentamicin to these preparation. So these are the different doses of these drugs. You can even stop this video and you can even read from this video, but I will skip it quickly because it doesn't need any further discussion. You can use that 10 to 20 million units if you are using the benzathine, so you can use on the weekly basis in the form of intramuscular injection. But if you are using the benzyl penicillin, you will have to go for the IV route. Adverse effect, remember, penicillin is a very good drug. They are very safe drugs, but again, there may be some adverse effect like hypersensitivity reaction and anaphylaxis. These two things are very, very important, hypersensitivity and anaphylaxis, and due to these reasons, we gave the test dose. Okay? The rest, you can say that it causes nausea, vomiting, diarrhea, it can cause the super infection, it can cause so many other adverse effects, but these two are very, very important. These two are very important. It can cause super infection. It can cause the other important adverse effect is the Jarisch-Hexamer reaction. Jarisch-Hexamer reaction occurs if you are treating syphilis with this drug. If you treat a patient with syphilis with benzyl penicillin or benzathine penicillin, there is killing of a lot of spirochetes, and because of the killing of the spirochetes, the treponema, a lot of intracellular material, they come out, and person can develop allergic reaction to those chemicals, and they can develop fever, rash, irritation, urticaria, and even even they can get psychosis type of reaction. So in such condition, you can give the aspirin and you can sedate the patient. That geriatric eczema reaction usually occur with these drugs. Then other adverse effects like local irritation at the site of injection, mental confusion, muscular twitching, convulsion, bleeding. If you use it intrathecally for the treatment of meningitis, there may be arachnoiditis and other degenerative spinal disease. This may be an adverse effect of these drugs. Now coming to another drugs, the semi-synthetic. So these were the natural penicillin, the penicillin V and the benzylpenicillin. Benzylpenicillin is further converted into benzathine and procaine by adding benzathine and procaine. And the other penicillin are the semi-synthetic. Semi-synthetic, why semi-synthetic are better than the natural penicillin? Because semi-synthetic are given orally. Semi-synthetic have got broad spectrum of activity. Semi-synthetic have got excellent susceptibility to penicillinase, which is an enzyme responsible for the degradation of the penicillin, and there is least chances of the hypersensitivity. So in case of semi-synthetic, we have two groups. One is the penicillinase resistance, that is the methicillin, cloxacillin and decloxacillin, while the other one is the extended spectrum. In extended spectrum, we have further three groups: the aminopenicillin, which is the ampicillin and amoxicillin, then the carboxypenicillin, which what we have the carbenzylline, and the third one is the uridipenicillin, which is the piperacillin. So these are the different groups. You can just stop this video and you can read these groups. You can even read all these things from different books as well. So for the penicillinase resistant, the name show these are the drugs which are resistant to the penicillinase, the beta-lactamase, the enzymes which is produced by the bacteria and which is responsible for the degradation of the penicillin. So these are penicillinase resistant. These are methicillin, nephicillin, cloxacillin, decloxacillin, flucloxacillin. These are in oxacillin. These are the different sort of drugs which are common with the common other antibiotic. We use specific antibiotic like vancomycin, linezolid, ciprofloxacin, cefepime, which is the fourth generation cephalosporin. We use these drugs for the treatment of MRSA. Then the other penicillin, which are the extended spectrum, we have the aminopenicillin. Amoxicillin is one of the important drugs. Amoxil, augmentin, and so many other names for this drug. It's very important. The second one is the ampicillin and beccampicillin. And then we have another group, the carboxypenicillin. We have the only drug that is the carbenzylin, which is not routinely available in the market and which is not in use commonly. And the third one is the uridipenicillin, in which we have got a very beautiful drugs, that is the piperacillin, which is available in the name of Tenzo and so many other names, and it is used for severe sort of infection. For severe sort of infection, it is usually used. This is just a comparison between the ampicillin, amoxicillin, and beccampicillin. All of them, they can be given orally. All of them, they have got the same plasma half-life. All of them, they have got almost the same spectrum. All of them have got almost the same adverse effect. So इसमें इतनी ज़्यादा there is discussion की ज़रूरत नहीं है. There is no need of any further discussion. You can just stop this video and you can read these comparison one by one. Otherwise, for me, there is and you can read all these things from there from these slides. So the other one is the other group is the carbenzylin. Carbenzylin, again, it is not that much in routine use, but we use it for the Pseudomonas and for the Proteus. This is the only difference in this carbenzylin apart from the other from other penicillin. This is the only difference. The rest mechanism, adverse effect, and almost all the things, they are same as that of the other penicillin. And the last, we have the uridipenicillin, which is the penicillinase, which is the broad spectrum, and it is a beautiful drug. It is active against the Pseudomonas, the Klebsiella, the Enterobacteria, bacteroid. It is acid labile, so we usually give it IV or IM, and it has got a few adverse effects. So I can say it's a very good drug for serious infection and for those people who have got life-threatening disease. So we use And last, this is the summary of all these drugs. You can stop this video again and you can read all these things, but I will make it short for you. There are natural penicillin, penicillin V and penicillin G, and there are semi-synthetic penicillin. In natural penicillin, we have penicillin V, which is given orally, penicillin G, which is given parenterally. But penicillin G, what we also call as the benzyl penicillin, has short plasma half-life. Its plasma half-life is lengthened by adding benzathine or procan. So it's become either benzathine penicillin or procan penicillin. We use it for the upper respiratory, for the lower respiratory, for the syphilis, for the prevention of rheumatic fever, infective endocarditis, and for so many diseases we are using these drugs. We have already discussed it. The other group is the semi-synthetic. Why we call them semi-synthetic? The structure remains the same as that of the natural penicillin, just at the level of R we add different ions and we just change the nature of the penicillin. So we can call them as the semi-synthetic. In semi-synthetic we have got the extended spectrum, and we have got the penicillinase resistant. In penicillinase resistant, we have the cloxacillin, methicillin, nefcicillin, decloxacillin, flucloxacillin. So you can use these drugs where you are suspecting bugs which are secreting more and more penicillinase enzymes. But we are just using methicillin in the lab to detect the MRSA. In routine, we do not use these drugs in clinical practice commonly. And the other group is the extended spectrum. In the extended spectrum, we have got the aminopenicillin, in which most important drug is the amoxicillin, which is present in the amoxil and augmentin, and we are using it for so many conditions. We are using even it in H. pylori infection, upper respiratory, lower respiratory, genitourinary infection, skin infection. We are using it for so many conditions. The other group is the carboxypenicillin. In carboxypenicillin, we have only one penicillin, that is the carbenicillin, which is active against the Pseudomonas and Proteus, and that is its only characteristic. But routinely, we are not using this drug. And the most commonly used drug in war and for the serious patient, that is the uridopenicillin, and that is the piperacillin, which is available in combination with the tazobactam, and we are using it for so many severe disease. So this was all about the penicillin. Hope this revision is very good for you. You come to the lecture, you attend the lecture, and then you go study the book, and you again listen to this short video, and I think you will really understand the whole mechanism and the whole process of this penicillin. So thank you very much. With this, I came to the end of my presentation. Please don't forget to subscribe my channel, like it, share with your friends and other colleagues and other medical colleagues.